Good morning. This is Dawn Monahan, and today we're going to discuss newborn nutrition. This material comes from Chapter 19 in your Flag and Pilitary textbook, and you can find this PowerPoint on your Moodle account. The first thing that we're going to address is the components of and structures that are found within formula and breast milk. The components of formula, and when we break it down, is easier to discuss because it is man-made, whereas breast milk is made uniquely by the woman for her baby. And we know that breast milk is different from woman to woman if we study it. So first and foremost, let's talk about the needs of the newborn. If you were to break it down calorically, newborns need about 110 to 120 calories per kilogram per day. So the way that's calculated is you take the baby's weight, convert it to kilograms, multiply it by those numbers, and that's how many calories the baby needs to get in a 24-hour period. Of course, we divide that up over the number of feedings that the baby would need throughout the day. Babies, as far as protein are concerned, newborns will need 2.2 grams of protein per kilogram per day. We know that newborns needs fat in their diet. Linoleic acid in particular is important as the neonate grows, especially in that first 4 to 6 week period. The carbohydrate, the basic form of carbohydrate, lactose, is the primary source of fuel and energy for the neonate, and the volume that neonates need is between 150 and 200 mLs per kilogram per day. So again, when we look at the intake of the neonate, we can convert their weight to kilograms, multiply it by these numbers, 150 to 200, and we should be seeing that the neonate is taking in volume close to that number per day. And again, we'll talk about breast milk a little later in this discussion, but when we look at the formula feeding baby, we can do that. It's easily measured, and we can confirm that they're in the proper range. Breast milk and formula, for all intents and purposes, formula is produced at 20 calories per ounce. That is how the manufacturers are making formula. Formula can be manipulated, so there are higher calorie formulas that are available on the market. We'll talk more about adding calories and supplementing formula with the necessary nutritional components when we talk about the compromised neonate later this semester. For now, we're talking about the normal healthy newborn, and that normal healthy newborn will receive approximately 20 calories per ounce. And breast milk is, again, different when we study breast milk from woman to woman. But again, it's somewhere in the range of 20 calories per ounce, some less, some more, depending on when we sample that breast milk. The important minerals that are also considered for neonates is that they have to be taking in adequate calcium, iron, fluoride, and vitamins, and vitamin D in particular. A few side notes on these minerals. Iron, because of the immature nature of the liver, and we know that it can take up to 6 months for the liver to actively synthesize and allow iron to work as it needs to, that it's typically formula is fortified with extra iron, and pediatricians will make recommendations to the mother if she's breastfeeding when it comes to things like fluoride. So fluoride is found in our water supplies throughout this country, and if the woman is not taking in enough fluoride, or if parents are not using tap water to mix and make their formulas, then the pediatrician may find that they need to incorporate fluoride into the normal health care for the infant. Vitamin D, also we've learned that as even adults, there's often a deficiency because of our lack of light and absorbing light. So vitamin D is something that we are now paying close attention to. So breastfeeding, we're going to jump from just the components and the requirements of newborn nutrition and into breastfeeding. Breastfeeding is recommended. It is the optimal way to feed a neonate. It is human milk made for the human belly. And your textbook goes into the physiology of breast milk production, and there's about a page and a half there. Understanding the physiology of how breast milk is made is important when we're counseling and promoting health with our breastfeeding population, because we have to always remind, especially first-time breastfeeding mothers, that milk is something that we have to stimulate the production of. So we know that when progesterone falls off right at delivery, as soon as that cord is cut and clamped, the progesterone levels that are circulating in the mom will fall off dramatically. But with that comes a surge in prolactin. So the fall off in progesterone triggers the increased amount of prolactin. We also know that when the neonate is placed at the nipple and the baby begins to suckle, that mom will release or have an increase. It stimulates the release of oxytocin, which also will further enhance the levels of prolactin that are circulating. So there's basically a number of things that are happening. The birth will be the first thing that triggers milk production, but the frequent stimulation by assisting the baby to the breast will also enhance the production of milk. It's sort of like a supply and demand. The more that the milk is removed from the breast, that includes the colostrum, the more often that baby is put to breast and stimulates that hormonal response, then the message is sent to the body, it's time to make more milk. So some of the advantages of breastfeeding, and there's really three. We can look at baby, mom, and family. For the baby, the advantages come immediately right after birth, and that is that colostrum is full of immunoglobulins, antibodies that are passed through that colostrum to the neonate. We know that babies who are breastfed tend to have lower incidences of GI disruption or interruption of feeding. So, less intolerance, less gastric distress, less rejection of the formula. And I'm sure you're familiar with the incidences that exist when we work with formula, that sometimes babies don't tolerate the formula that they're given. So then you're back at their doctors, let's put a plan together. Is the baby spitting? Is the baby have diarrhea? Is there lactose? We don't see that happening in our breastfed population. It's very rare that happens. The other very reliable data shows that there is overall, as we track and trend children who were breastfed throughout their childhood and into adulthood, they have a significantly lower rate of obesity than their formula-fed counterparts. So there are some real measurable benefits to breastfeeding for the baby. For mom, the benefits are that her uterus is definitely going to have really increased and efficient contractions because of that stimulation of the oxytocin hormone, which helps the uterus contract and involute back to its pre-pregnant size and shape. And the caloric needs for the mom are up when she's making milk. So many breastfeeding women will share their pleasant side effect of breastfeeding in that they return to their pre-pregnancy weight sooner as a breastfeeding mom. And then the benefit of bonding, the perceived experience by women who are breastfeeding is that they feel close to their baby. And that's not to diminish the bonding that can occur when we're not feeding a newborn. Certainly partners take that opportunity to just do skin to skin or spend time with their child or their grandchild or their niece or nephew. But there is a lot of data out there that supports breastfeeding promotes good bonding. And then finally, for the family, there's benefits of breastfeeding to the family at large. That is that it's easy prep. We don't have to worry about packing up a diaper bag and running out and heating bottles or worry about where our water source is. Easy travel. And then finally, it's affordable. It's free. It's made by the body. So that's a real legitimate benefit for many parents that I've worked with throughout the years. So there are some contraindications to breastfeeding, and those things would be like certain types of medications, unmanaged substance abuse, substance use disorder, that's the proper term for it. And how is that defined? Women who are in a substance use disorder program or a weaning or withdrawal program, such as like a methadone program, if they're managing their substance use disorder and they're attending to that clinic and they're following their program, those women are encouraged and supported in the event of breastfeeding their young baby. Women who are not compliant in a substance use disorder program are at risk for substance use, meaning that they might be using more than just their withdrawal medication like methadone or Suboxone. These women, we would discourage them from feeding their neonate because of there could be risk to the neonate. Galactosemia would be, in the infant, would be a reason to not breastfeed. Active herpes lesions of the breast, on the breast, that would be a reason. Herpes lesions elsewhere on the body would be okay to breastfeed, but on the breast, not so. HIV is currently a reason to not breastfeed. If mom is undergoing any kind of radiation actively at that time, breastfeeding would be discouraged. If mom has an active case of TB because of the airborne nature, we would ask her to withhold breastfeeding. And if she's undergoing chemotherapy, then that would be a reason to not breastfeed as well. So some of the techniques of breastfeeding, and they're listed out here on your PowerPoint, that you want to just be familiar. These are the areas that we have to address as nurses when we're supporting our breastfeeding population. And the first thing that every parent always asks is, how often do I breastfeed my baby? And our answer to that question is on demand. That's hard in a world where we are focused on time. So frequency matters because we want that baby to go to the breast frequently, because remember, it's all about supply and demand and stimulation. And as the baby gets to the breast more often, then we know the stimulation, the milk is being made. Does it mean in those first 72 hours that the baby's getting large volumes? It does not. And frequency in the first 72 hours is really less about volume to the baby. We know the baby has enough to sustain his or herself in those first 72 hours. The frequency in the first 72 hours is really about stimulating the production of milk. When we get outside that, once the milk has come in and we're outside that 72 hours, the frequency then has more to do with volume and that the baby's taking enough volume to remain hydrated and nutritionally sound. Positioning. The position of the baby at the breast is crucial when it comes to nipple integrity. Position is the number one reason, position and latch is the number one reason why women experience nipple breakdown. So that would be bruising, blistered, broken, bleeding nipples. When we see that in practice, it's clear to us as the clinicians that there was some feeding instances where perhaps the baby wasn't positioned properly. The proper position for breastfeeding, regardless of the hold, because holds are how the mother is holding the baby, and some of the more common holds are the Madonna hold, the cross cradle hold, the football hold, or the side lying hold. Those holds are simply how the mom holds on to the baby as she brings the baby to her nipple. And notice I said brings the baby to her nipple. Mom should not be bringing her breast to the baby. Mom should be bringing her baby to the breast. But the positioning is crucial because that is really about belly to belly. So imagine a piece of Velcro on the baby's belly and a piece of Velcro on mom's belly. That baby should always be, for all goals, should be that that's belly to belly, and that baby is facing the breast, not turning to the breast, but facing the breast. When we talk about latch is about how then does that baby take their jaw, and notice I said jaw, not mouth, jaw, and open that jaw and get onto the nipple and the extended areola and perhaps even the breast, depending on the mother's size of her breast. So it's a nice wide action. So one of the things that when I'm working with moms, I often say is we call this breastfeeding because the baby should be on your breast. It's not nipple feeding, it's breastfeeding. We want mom to take in as much of the breast as the baby to take in, as much of the breast as possible. And it's important that parents understand that. So that, because if the baby's on the nipple and just sucking away on the tip of that nipple, not positioned properly, not latched properly, that is going to create a lot of damage to the nipple tissue of the nipple. Duration on the breast, ideally, the goal in the first 24 to 48 hours is to get the baby on breast and have that baby intermittently sucking actively, latched on the breast for anywhere between 8 and 10 minutes. We know that the stimulation of the hormone oxytocin occurs within 1 to 3 minutes, but the body needs, the anterior pituitary needs that stimulation to occur for at a good 8 to 10 minutes, because that will ensure that milk really is being made. So a breastfeeding time of less than 5 minutes, the mom may have felt some contractions, maybe there was some stimulation going on, but the literature and the data suggests that it's those feeding attempts or successful feedings that last greater than 8 to 10 minutes that really contribute to supply. Breast and nipple care, women should, when they're done with feeding their infant, they should take proper care of their nipples in that they would let them air dry. The latest literature does suggest that colostrum in particular, and breast milk that will come in after the 3rd day, and breast milk may offer benefit if it's gently massaged into the tissue of the nipple and areola. Moms should let that air dry before they refasten their undergarment or place any pads in their undergarment. And as far as the creams that are available, we know that aloe and lanolin, and there's lots of aftermarket creams available for nipple care, that those should be applied after the use of colostrum and breast milk. So first it would be the colostrum and breast milk, let them air dry, and then if we're using the aftermarket products, those could be gently applied for comfort and healing. We don't put it on before feeding, we put it on after feeding, and there is no need to wash that from the nipple. And then adequacy of breastfeeding, how do we measure that it's adequate and it's meeting the needs of our newborn? Well, we simply pay attention to what the newborn's doing, in particular their diapers. So in the first week of life, adequacy is the best way to measure adequacy is to count their wet diapers. So we're talking about a truly wet diaper, like we're certain the baby voided. And we look at the baby's age in days of life, and it should mirror or match the number of diapers that the baby has. So in the first 24 hours, we expect to see at least one wet diaper. At 48 hours, in the second 48, we need to see at least 2 wet diapers. So that on the 4th day of life, I should see at least 4 wet diapers. And once the milk is in, which again, every woman's different, but we expect it somewhere between the 3rd and 4th day, and they progress to that 6 to 7 day mark, we should be seeing a minimum of 6 to 8 wet diapers by the end of their first week. Most babies give us far more than that in voids, but that is a one way and a very easy way to manage and measure, is the baby getting enough? The other ways that we can do that are also by tracking weights. We could do daily weights to see what those weight shifts are. We know that all newborns, healthy newborns, we expect that they're going to lose about up to 10% of their birth weight by 72 hours old. So, and then we can also look at the baby's overall activity. Are they lethargic, or are they waking and they seem alert and they're not withdrawn? And then also we look at their jaundice. So babies who are dehydrated are at much greater risk of jaundice. So if we see the jaundice levels increasing, we have to wonder if they're getting enough. So latch scores, you might be seeing these out in the clinical area, and I just used this slide to kind of give you an acronym of what latch stands for. L being the latch itself. A being the ability to hear audible swallowing on the part of the neonate. Swallowing in the neonate doesn't sound like our swallowing. It sounds like a little nick, like this. So it's kind of a little tiny sound. You have to really get in there to hear it. The type of nipple we assess, whether it's everted, flat, or inverted. Women with any type of nipples should be able to breastfeed, but if they have flat or inverted nipples, it may require some assistive support on our part with teaching mom on how to best work her nipple to give her baby something to latch onto. C stands for condition of the nipple. Is it intact, or are there signs of reddened areas and blisters, or is it just broken and bleeding now? And H is how much help was needed on the part of the mom to get this baby to successfully feed. So we score latch much like you learned about APGARs, and that's we give a 0, a 1, and a 2. 2 would be an ideal condition. 1 means that there's, it's not perfect and we need to kind of provide some support in this area. And 0 means it's not happening. So for instance, if we've worked with a mom and a baby for 20 minutes for the baby to latch, and the baby never really truly latches in that 20 minutes, well, then I have to assign a 0 to the L. Another interesting thing about audible swallowing is that to get a 2 for audible swallowing means that we hear the baby continuously swallowing. That is impossible in day 1 or 2 unless the mother really does have breast milk, but that's unlikely. So for most babies in the first 48 hours, it's going to be intermittent because they don't have a steady stream of breast milk. That we're expecting to see that between day 3 and 4. So it would likely be an intermittent swallowing that we're hearing. And again, we've talked a little bit about those condition of nipples and the help. So if they're breastfeeding independently, they get a 2. If they're breastfeeding with a significant amount of assistance from myself or yourselves in the clinical setting, then they would get a 1. And if it's me who achieves the latch and the mom just can't do it, well, then that would be a 0. So we do this because it gives us measurable information so that we can score how the breastfeeding's going. Is it getting better? Is mom becoming more independent? Are there issues? And women who have less than a 7 on a latch score, we know there's a risk that they're not able to provide what they ideally need to provide for their breastfeeding newborn. Now, women do have the ability to express their breast milk, and in the first 2 weeks of life, if women do have to express their breast milk and they have a healthy baby, we encourage manual expression, and your textbook does have some photographs that show how to manually express. However, if women have a baby that they have to be separated from or is sick, maybe a NICU experience, then sometimes that baby can't get directly to breast. We need to set that mom up with pumping. And pumping is typically something we do on a schedule because remember, frequency matters. So we would have her on a every 3-hour or Q3-hour pumping schedule. She would then need to be taught how to store her milk. Milk storage is either going to happen in a typical conventional refrigerator or a conventional freezer or a deep freezer. The deeper you place the milk into freezing, the longer it will last. So deep freezing, if you deep freeze milk, it's good for 6 months, breast milk. In the freezer, it's 3 months. And when we store milk in the fridge, it depends on the sources that I use to develop this lecture. Between your textbook and outside sources, the current literature is that breast milk is stable. Stable meaning it doesn't break down. Is stable in the refrigerator for up to 7 days. So some texts will say 5, some texts will say 6, but there are also other sources that say up to 7 days. It has to be dated and timed, and we always do that with something that is non-porous and that would never, like, we don't want marker leaking through the labels into the milk. So we teach parents to either put it on label tape and then affix it, or there are bags out there that are available to parents to buy that you could write on the bag because they're non-porous. A side note about breast milk: it should never, ever be microwaved. Microwaving breast milk is very fragile, and when it's exposed to those high levels of radiation in the microwave, it actually breaks down all those wonderful components and nutritional components of breast milk. So it's something that we want to make sure we're passing that along. We're not supposed to microwave anything that we give a baby. That is not the preferred method of warming anything, and we don't teach warming even with formula-fed babies anymore. We teach room temperature. So it can be just letting it sit for 20 minutes before you give it. But if we're thawing and defrosting, parents need to be taught that we're not going to use the microwave to do that. And just so you know, if we have a healthy neonate and we're going to feed that healthy neonate, we have to have pumping start ideally after 2 weeks because we want to establish a good latch.